Hello, Yavapai County. My name is David McAtee, and today I'm here with Dr. Robin Timme, who is with Falcon, and we'll get to that in a little bit. But for those of you who haven't been watching these videos, Yavapai County is in the process of building a justice center here in Prescott. And one of the things that we like to do is keep people informed. And so we're doing these videos to let people know where we're at in the process, but also to let you know why we're building a justice center. And one of the things that we looked on early on is the behavioral health aspect of justice or justice system. And so we contacted Dr. Robin Timme, and just a brief little bit about him. He is recognized as a leader in correctional behavioral health across the country, frequently speaking and teaching at national conferences and supporting innovative programming. Dr. Timme has practiced in the field of correctional and forensic psychology throughout his career, shaping policy, supervising behavioral health clinicians, and handling evaluations at high risk and high needs inmate patients. So welcome, Dr. Timme. Thank you for joining me.
Thank you. Great to be here.
So one of the more interesting things and one of the more interesting aspects of this project is the behavioral health unit that is being constructed as part of the new Justice Center facility. And some may ask, why are we including a behavioral health unit at a justice center? So today we're talking to you, and you and your organization, Falcon Correctional and Community Services, have played a large role in the development of this aspect of our new Justice Center. So can you tell me how much of what goes into a correctional system is affected by behavioral health concerns?
Yeah, sure. Well, first, thanks for having me on today. It's really great to be here. I've really enjoyed working with Yavapai County, and I'll get into some of those relationships a little bit later. But unfortunately, behavioral health plays a huge role in correctional facilities today, and really across the justice system. We've known for a long time that the population of those who find themselves to be justice involved tended to have higher rates of both somatic and behavioral health conditions. They're less likely to be insured. We're less likely to be receiving treatment for those conditions in the community before they come to jail. And as a result, we know that the rates of medical and behavioral health conditions, those including psychiatric and substance use disorders, are several times greater in the detained population than they are in the free world. Some estimates are as high as 80% of the population in a jail will meet criteria for a mental illness or a substance use disorder. We also know that there's a lot of overlap between the systems of public health today and the systems of public safety. And many of the individuals are super utilizers of emergency departments as well. So they get their care either in the emergency room or, unfortunately, in a jail. So a lot of times we forget that those systems of public health and public safety overlap so significantly. In the middle part of the 20th century, we recognized that we were institutionalizing people with serious mental illness at alarming rates. We were placing a lot of people into state psychiatric facilities and keeping them there far too long. And so there were efforts to de-institutionalize and to push people back out into the community so that they could obtain care in a less restrictive setting and live fuller, more healthier lives without having to live in an institution at all. Unfortunately, the supports that were supposed to be in place never really came to fruition. And there was the advent of lots of different problematic issues like the Vietnam War and crack cocaine. We know that people with serious mental illness, for example, have very high rates of co-occurring substance use disorders. And so what ended up happening is that they found their way into the justice system and began to become criminalized. And ultimately, according to some more recent research, there are significantly greater levels of serious mental illness inside today's jails and prisons than there are in state hospitals today. Some studies show as high as tenfold, approximately 35,000 people with serious mental illness in state hospitals across the country, and about 350,000 in correctional facilities across the country. So, and while that seriously mentally ill population has gotten a lot of attention in recent years, and many jurisdictions have become fairly adept at identifying, treating, managing, and connecting that group, more recently, systems have begun to use tools like the sequential intercept model to deflect this population entirely, meaning if we can identify them early enough in the system or early enough in the criminal justice process of arrest, detain, booking, charging, prosecution, we can actually minimize or even eliminate the justice footprint for this population that really doesn't necessarily belong in jail. And we can connect them to community resources that can reduce the likelihood of them coming back to jail or being rearrested. One other thing that a lot of people don't recognize too is that it's only a very small fraction of the detained population in jail that goes to prison. Better than 9 out of 10 people in jail today are going to go home. They're not going to go to prison. And so that's a really important observation. And it really obligates us, I think, to do something while they are detained or to keep them out of jail to begin with in a way that restores them as they go back to the community, back to their families, and back to the places where we all live and work. The other point I'll make is that serious mental illness plays a really large role in this conversation, but it's still a small number of folks who are in the jail. So I would call it a large minority of the folks, maybe 1 in 5. But there's a much larger issue in terms of what we would call trauma or childhood adversity, people who have survived sometimes very horrific situations in their lives. And we know that childhood adversity is predictive of all kinds of negative outcomes, including illnesses, depression, suicide, intravenous drug use, crime, and even early death. And so providing trauma responsive interventions to meet the needs of those outside the seriously mentally ill category is really critical. And then the last thing that you might not even realize you're asking about is that the people who work within correctional facilities, the staff, we've learned a great deal in recent years about those of us who have delivered services inside facilities. Studies show that our staff are exposed to uniquely toxic stress, an environment that contributes to elevated levels of all sorts of somatic and behavioral health conditions among the staff as well. We see things like high levels of obesity, heart disease, depression, suicide, many other ailments, to say nothing of staff turnover, use of paid time off to cope with stress, and other manifestations of the trauma that are honestly very expensive to deal with as well. And so those traditional models of jailing, the way that we've done criminal justice to date, has not been the most evidence-based or trauma responsive, or to be perfectly honest, fiscally responsive either.
And I know one of the first things that you were asked to do when you came on board was to look at our current system, how we are handling behavioral health issues within our own correctional system. Can you tell me a little bit about what you found we were currently doing and what were some of the suggestions that you made for us going forward?
Sure. Yeah. So one of the things that was great about this project is that when I came into the county, there was already a really impressive effort underway that included close collaboration between the sheriff's office, the county, local behavioral health providers, and even the county facilities department that's ultimately tasked with, building facilities. And that was really refreshing for me to come in and see that so much work had already been done. And we were being brought in to sort of validate what was going well, what they had already sort of proposed, to make tweaks to the system in any way that could improve it, and then to ultimately make some recommendations about right sizing a facility. So how large, how many beds, how many offices, things like that. And so we worked really closely with the Yavapai Justice and Mental Health Coalition and their executive director, Bea Thayer, as well as with Sheriff Masher at the time's team and Chief Deputy Dave Rhodes, now Sheriff-elect Dave Rhodes, as well as the Board of Supervisors representation to look at sort of historically, how did we get to this point? And when we look back, the county had done a really good job of studying their system. In 2015, they commissioned a study that resulted in some specific systemic interventions, some recommendations that I believe each one of them had been implemented to some degree. And the one that was, I think, most powerful, or maybe two, was the creation of an interdisciplinary stakeholder group. When we look at places across the country that have really overhauled their justice systems and really elevated the way that they're doing justice in their communities, it starts with a group of qualified, invested leaders that span disciplines, not just law enforcement, but also the courts and behavioral health providers. Hospitals are very invested in this. And Yavapai County had a very impressive group that was really motivated, had a lot of ideas, knew each other very well. They may have been coming at it from different angles, which is exactly how it's supposed to be. That's why they're at the table. But the mission was the same, the superordinate goal of public safety, of public health, of elevating the way we deliver justice in the county, was all very clear and really nice to see. They knew that they wanted to focus on two kind of specific populations. One being the population of people with serious mental illness or who are actively in an addiction or a behavioral health crisis. And how do we decriminalize a behavioral health crisis? And so through what's called the Title 36 process, which is the involuntary civil commitment standard in Delaware, in Arizona, is the police have the authority to detain somebody without actually arresting them. However, they struggled because that person often needed to go to an emergency room to get cleared. And what we see across the country is that there are approximately $8 billion wasted annually on unnecessary psychiatric use of an emergency room. And so part of the problem was in the community. We were trying to solve a community-based problem, not just a jail-based problem. And this group was really good at quickly realizing that we're talking about a system. It's not a building. The building is one very important piece of a much larger system that includes hospitals and community behavioral health centers and the drug and alcohol treatment providers in the community, as well as those in the jail. And so on the front end, they wanted to create a model where the police or mobile crisis providers could take somebody who's experiencing a behavioral health crisis and bring them to a co-located place. So a spot on the same grounds as the jail, but not actually have to arrest or book the person into the facility. And so if the crime, so to speak, and these are low-level crimes, misdemeanors, very low-level offenses, sometimes people think of it as, but for the mental illness, the crime wouldn't have been committed. This might be somebody trespassing under a bridge or being drunk in public, things that, locking them up for a couple of days, which is probably how long they'll be in jail, doesn't really solve the problem. You talk to some of these police forces, they'll tell you that they have arrested people and taken them to jail and seen them back on the street on the same shift. And so we're not really doing anything to interrupt that cycle. So the front end was the creation of a secure psychiatric unit where people can stabilize, where they can be diagnosed. They can decide to go voluntary into treatment, at which point they would leave and go to a voluntary civil psychiatric hospital. And then on the back end of the system, those who did need to get booked into the jail, maybe they committed a higher level offense, maybe the police didn't think that they met the criteria necessary for that Title 36 process. They may go into the jail for a day, a week, a month, but when they get released, there's now a co-located facility that also provides them with a community linkage on site that can be staffed by those behavioral health departments that are in the community. They can do their substance abuse and mental health intake right there. They can maybe check in with their parole and probation officer right there and greatly enhance or increase the likelihood that they are going to be able to desist from the behaviors that brought them into jail in the first place. And that's really what reentry is about. And so the front end service and the back end service is able to be done in a co-located space, a building right next to the jail that everybody will walk through before they get picked up to go home after their time in detention.
So that's where we get this term warm handoff. So it's not just you were arrested, you're out on the streets now, go take care of yourself. It's a warm handoff to someone who is going to help you get the services that you need. And maybe that's seeing a doctor for new medications or a counselor or whatever it is. That's that warm handoff.
That's right. That's exactly right. And there's a saying in corrections that we take very seriously, that is, reentry begins at intake. Yeah. So the moment that the person comes into booking, there's a really wonderful project that the sheriff's office put together with the Yavapai Justice and Mental Health Coalition called the Reach Out program. It's been studied by NAU and some other places it's a really cool program. Basically, they come through the front door and very quickly, within hours, they get seen by a Reach Out coordinator who does an assessment of the person to see what it is they need. And so that information can then be used as part of the reentry planning process for this person. So let's say the person really has a drug addiction that they haven't done anything about, and the court is really fed up. Now the court can say, look, I don't want to put you in jail. I want you to stop using the drugs that led to the criminal behavior that brought you to jail. So let's have you access treatment. And guess what? They can leave that booking area or that courtroom and walk directly into a space where they will get the intake into the treatment that was just required of them. So yes, a warm handoff today means bringing the community into the jail or onto the same site so that before that person goes home, they've gotten connected with treatment to begin with.
So they're literally on the same property. They're walking them out one door in the next door and making sure they're getting in the hands of those that will give them the direction they need.
Exactly. It's this model of co-location, everything in one place. In this model, you have a jail, you have a courthouse, and you have what's called the co-located facility for that front end service and the back end connections.
And I know whenever we talk about these very sensitive subjects, no one really wants to talk about money because that seems so insensitive. But realistically, this is going to cost us money to build and maintain. And I know that we're involving a lot of the different mental health, behavioral health organizations within Yavapai County to kind of support this. But is this costing us money, or is it really in the end saving us money?
So that can be a hard question to answer. So the first thing to think about anytime you're going to build something, right, is that you have capital costs and you have operating costs. Will it cost something to build this structure? Absolutely. Those capital costs are going to be required up front to actually build the facility itself and get it functional. When it comes to operating costs, though, we see these types of facilities become almost cost neutral. And in some places where we've been working on them, they actually can be profit centers for the county. And I'll explain why. So for a long time, those healthcare services that are delivered inside of jails and prisons have not been eligible for reimbursement from third-party payers, specifically Medicaid dollars across the country. And as a result, the county has had to bear the cost of those services. Very expensive. I just articulated all of the somatic and behavioral health conditions, and it is settled in the courts across the country that there's a constitutional obligation to provide minimally adequate services. So somebody comes in with cancer, the county is going to have to foot the bill for that treatment, and that's just the obligation that has been upheld by the courts. However, the minute that treatment is provided out of custody and is voluntary, then those funds become available. And so the way that this facility is designed to operate on the reentry side of it, where you will have intake for behavioral health providers, psychiatric providers, addiction providers, is that those services can be provided by community-based organizations, of which you have a very rich collection in Yavapai County, very, very talented and passionate folks there, good resources. You're going to bring them into this area that's no longer in custody and it's now voluntary. And so they can provide those services reimbursable by third-party payers and not have to provide that. The county will not have to fund those services or that staffing either. On the other end of the facility, the Title 36 end, that is involuntary civil detention. And so those funds are actually passed through from the state. So those dollars are already being spent on that population through other contracts. And now they'll be brought under the county's management, which will allow them to be more efficient with those dollars. But a lot of times people also forget that crime is very expensive. So we know that these interventions on the front end and on the back end can reduce recidivism. So they can reduce the likelihood that somebody commits a crime again. And in order to arrest to detain, to put somebody through the court system, to house them, to sentence them, to feed them. These are very, very expensive systemic issues that we see. And it's always going to be less expensive to keep people out of custody. If you want to think about also in terms of dollars and cents, there was a study that was done in your probation and parole realm of the county system that showed substantially less cost for somebody to be out of custody than to be in custody. I believe the number may have been, and I'm shooting from the hip here, but I think it may have been about $100 a day to keep somebody in the jail and about $2 a day to keep them on pretrial supervision or on probation outside of the jail. So fewer people in the jail should save money for the county. And at the same time, it's also, there are other kinds of costs, right? We know that there's a human cost to incarceration. And so as a psychologist by training, I'm always thinking about the clinical and the ethical best practices. And from what I know, I would say that it's always better to keep people out of jail if public safety and community restoration are the goal.
So you said early on that a large percentage of the people getting behavioral health support are receiving that in the correctional system, and whether or not that's where they should be getting it or not, I think is a discussion for another day. But I guess the question is, are these things that we've talked about today, is that preparing us or making us better at offering those services?
Yeah, so a lot of what I talk about today are what we would call like a both and strategy. So it's not either focus on community behavioral health or focus on the jail. They're linked. They're sort of one and the same system. And so you're absolutely right. I think we've done a better job in recent years of quickly identifying, diagnosing, treatment planning, and really providing evidence-based services for that population that does end up in custody. Look, if somebody has schizophrenia and they commit a heinous crime, that person is going to end up in jail, right? Now, maybe we won't have the astronomical numbers of people with serious mental illness in jail as we do today, but there will be people there. And so the newer models are looking at principles of normalization, for example. So the newer facilities look more like a hospital than they would a traditional jail. And people ask me a lot, if you were going to build a jail, what would it look like? And I say, well, I wouldn't build a jail. I would build a hospital and I would build a school and I would make sure that they're secure. Because that's really what we need for the people who are coming to jail today.
And I think one of the questions that I get, and frankly, it's one that I had, is, when we hear behavioral health, mental health, we really don't know what that means. I mean, you maybe picture, somebody laying on the couch with the guy sitting behind them, taking notes, asking questions, that kind of thing, or just a doctor handing out drugs. So what does it look like? What are the services and what is the environment? What does it look like when you voluntarily or involuntarily get into this behavioral health system?
Yeah. So there's a wide array of conditions that we might call psychiatric disorders. They're really just terms for a cluster or a syndrome of symptoms that exist. And they can range from very mild symptoms of anxiety and depression that maybe you and I experience on a Monday morning, knowing how busy your day and your week is going to be. That can be pretty stressful for people. All the way through what we might call more severe and persistent mental illnesses. And those are things that really are represented by breaks from reality, experiencing stimuli or symptoms that other people don't experience. So hearing voices other people don't hear, maybe seeing things other people don't see, or believing things that are objectively untrue. So you can imagine, for example, if I believe that you are trying to assault me, I'm going to defend myself. The problem is, if you're not really trying to assault me, my behavior can become criminal in that action. And so that's an example of how the justice system gets involved. But far more often what happens is that there are astronomical rates of substance use disorders. And that's why we use the term behavioral health crises. So somebody could be intoxicated on methamphetamine or on PCP, and their behavior is very bizarre, and they draw the attention of the police, and they end up accessing the system that way. So when you hear the term behavioral health, we really generally think of it as psychiatric and substance use disorders. And within each one of those, there are sort of mild, moderate, and severe presentations of those conditions.
Well, Dr. Timme, I truly appreciate your time today. Is there anything that we missed that you'd like to talk about?
I don't think so. I'm really excited for you guys to be moving forward on this project. This model, I will say that this model is becoming more and more popular across the country. A couple of final points that I'll make about this model is that for people who are advocating for decarceration, to advocate against mass incarceration, like many of us have been advocating for years and years, this is a really creative solution because it actually deflects people from the jail back into the community. And so it's a really powerful systemic overhaul that can really speak to that term decarceration. The other term that we hear a lot about today is defunding and defunding the police. And when I hear that, I think of reallocating resources. I don't think of just cutting policing budgets. I think of spending money more wisely in ways that actually contribute to public safety. And so this is another example of a model where funds are being shifted to out of custody programs that help people to stay out to begin with, and help people to reconnect to the community in a way that keeps them from coming back to jail to begin. And in that way, sort of redefining the relationship between police and the communities that they serve across the country. And the last thing I'll say is that, there are lots of jurisdictions out there today that are looking to do exactly what Yavapai has been doing. And I actually presented on this model at the American Institute of Architecture, the Association of Architects for Justice, a few weeks ago. And this model is really being called the Yavapai model. And we're seeing it all over the place as becoming very popular. And my guess is that in the next decade, this is going to become the norm. That this way of addressing and reaching the population of those in behavioral health crises and deflecting them from the criminal justice system altogether is going to be how we decriminalize behavioral health problems in the country.
Well, it sounds like Yavapai County is leading, which I appreciate hearing, and it sounds like we're headed in the right direction thanks in part to your support. So thank you very much for joining me today, and thank you for your help in getting us going in the right direction.
Anytime. Thank you very much. Merry Christmas.
Merry Christmas.